Hello everybody, I am Dr. Raktim and I am here to discuss on the topic of screening of a disease. Let us begin. So what do you mean by screening? The concept of screening goes like this. It is the search of unrecognized diseases in the community. The unrecognized diseases or defects that are in the community in an apparently healthy individuals. And these are detected by clinical examinations, various procedures or tests. So, what is the use of this screening? It is basically used for the detection of diseases in its early stage so that we can change the outcome of the disease, and thus the person who is suffering gets to know about the health status and take adequate action to prevent the disease or disability. However, we must ensure that the screening is very much different from periodic health examination. So what are the differences between periodic health examination and screening? We would be discussing this in coming slides. So let us move forward. So now let us discuss the differences between the two. Firstly, the screening tests have wider applications. It is done in the community level to all the individuals. However, but the periodic health examination is done in limited population, be it in a factory or an industry or in a school or in a particular age group. So it does not have a wider application. However, the screening have wider applications since it covers larger population. Screening tests are relatively inexpensive because when we do a screening test, we do it in a community at a larger level. The persons who come out to be screened positive, then they are subjected to various diagnostic tests and later they are labeled as disease positive or negative. But the main objective of periodic health examination is that in periodic health examination, we tend to diagnose the disease early. We are not going for screening there. We are more focused on the diagnosing a disease so that we get a healthy workforce. Thus, it is relatively expensive compared to a screening test. And lastly, in a screening test, these are the tests that are done in the community in the field level by field level healthcare providers like the ASHA, or in case of school health refractive errors, it is the school teachers. So they have very little knowledge of health compared to a healthcare worker or a doctor. So screening tests requires very little physician time. The only time when we require a physician in a screening test is at the time of interpretation. But in case of periodic health examination, it is done by a qualified health professionals only. So that was all about the differences between the screening and the periodic health examination. Let us move forward. Coming to the concept of iceberg phenomenon of the disease, it is a prime question for undergraduate level, and it often comes as a short note, or it may also come as a long question. So, what is an iceberg? See, this is the example of this is the figure which shows an iceberg. Iceberg typically is like when we see an iceberg, very little part of the iceberg we see, this part, and much of the part of iceberg is submerged under water, which we cannot see. This. Similarly, in iceberg phenomenon of a disease is considered here as an iceberg. What the physician sees is only the tip of the iceberg, this part. And these are the clinical cases that are present in the community and who are coming to the doctor or a healthcare worker for treatment. Much of the cases do not come to the healthcare system. They remain in the community as such. Even the persons those who are apparently healthy may not even know that their disease status. So those are all the hidden cases in the community. Okay, so in this analogy, the submerged portion, it represents the hidden mass of disease, and it remains hidden from the physician, from the healthcare system, and from the community. Screening here is of prime importance because with screening we get a chance to diagnose the disease in its early stage. So, to avoid the apparent disease from its subclinical stages, screening is important. Screening will help in early diagnosis. Early diagnosis will help in prompt treatment, and thus the natural history of the disease may get changed. That is the importance of screening for iceberg phenomenon of the disease. Now, coming to the aim and objective of screening per se, let us discuss one by one. Number one, screening helps us to sort out those individuals who have the disease or likely to have the disease. It is just like when you are going to the community and doing a screening program, say for hypertension or diabetes by checking the random blood sugar, then those persons who have the disease already or who are on treatment, they may get their health checkup done, they may get to know their status. That is number one. And number two, those who do not know whether they are diseased or not, it is a chance that they may get to know their health status. If they come out to be screened positive, then further tests can be advised, and then a specific diagnosis can be made. So, to sort out the individuals who have the disease or likely to have the disease, screening is important. Number two, it is done in apparently healthy persons. We already discussed about it. So, those persons may come under medical supervision and treatment. Thus, it helps us to alter the natural history of the disease. These are the objectives of a screening test. Moving forward, let us come to the concept of lead time. It is often asked in Viva in undergraduate level. Let us try to understand with the help of a simple diagram. This is the diagram where 1, 2, 3, 4 and O is the outcome. 1 means, suppose at this point a disease onset has begun. In due course of time, at point 2, it is the first possible contact where the disease can be detected by any means. Number 3 represents the final critical point where the diagnosis, if made, then with treatment the patient will come back to its pre-diseased stage. Okay, and number 4 is the usual time of diagnosis when all the signs and symptoms have occurred, and after that the diagnosis have been made. At this point of number 4, we will not be able to bring the patient back to 1 or before 1 stage, because it cannot be reversed back. Now, after point 4, we will get to know the outcome of that disease. There may be various outcomes. It may lead to spontaneous recovery, it may lead to carrier state, it may lead to a diseased state and finally some disabilities, or it may even lead to death. Those are all the outcome of the disease. So, where the concept of lead time come here? Let us understand. Screening tests are generally considered for diseases which have a time lag, between the disease onset and the usual time of diagnosis. That is number 1 and number 4. There should be sufficient time here. If this phase from 1 to 4 is very rapid, then the screening test will not work properly. If this time lag between 1 to 4 is big, then the screening tests have a role to alter the outcome of the disease. Moving forward, lead time is the advantage that we gain by early detection. Suppose if we can detect the disease at the point of 2, then the time lag between 2 and 4, this we have gained, and then we can even change the outcome of the disease. So with lead time, I mean it is the time that we have gained by early detection of the disease by some methods, and with this time gain we will be able to change the natural history of the disease. That is all about the lead time. One thing, do remember that if the time between the disease onset and the usual time of diagnosis is very less, then screening time or screening tests will have very little role, because even if we detect the disease early, we will not be able to effectively alter the outcome of the disease. Thus, we require a sufficient time lag between disease onset and the usual time of diagnosis and the outcome, so that we gain something from the screening tests. Let us move forward. This is again a diagrammatic figure where I have explained about the concept of lead time. From birth, this is the onset of the disease, and it is the first detectable point where the disease can be detected by any means. This is the final critical point where, if the disease is detected, we can revert back to the pre-disease period. This represents the usual time of diagnosis. It means clinically the signs and symptoms have occurred and the patient is visiting a healthcare system or the doctor, and the doctor is diagnosing after some tests. From here, we cannot revert back to the pre-disease state, and from here it is very difficult to change the outcome. From this stage, whatever treatment or management is done for the patient, it is only for disability limitation and rehabilitation of the patient. Sometimes the patient may get cured, but however, the patient will not recover 100% from this stage. So, if we can detect a patient earlier at this critical point by our screening tests, then the time lag between the screening positive detected and the critical point and usual time of diagnosis, this time lag is the lead time where we can alter the natural history of the disease. I hope you have understand the concept of lead time, why it is important, how screening tests play a role in lead time. Moving forward to the slide. Now, with this background knowledge, let us come to the uses of screening. Number 1, case detection. Till now, we have been discussing that screening tests will help to identify the hidden cases of the community or in the individuals, and later we will be able to classify them under certain stages, and diagnosis of the disease can be made. So, the first use of screening is the detection of cases. It is always prescriptive screening, because when we are doing prescriptive screening, we will be able to detect a certain case in the community. Here, based on the screening tests, the presumptive identification of the cases are done. Okay? Why I am saying presumptive identification of the cases? Because here we are not doing any diagnostic tests. We have to confirm the screen positive patients from an array or battery of diagnostic tests to classify or label them as disease positive. So those patients who are screen positive, they are only termed as presumptive identification of the cases. One thing to remember, that it is not done on patient's request. It is done to identify the cases from the community. It is initiated by the healthcare provider. The patients will not request for it. Moving forward now, this case detection can be made like it is generally seen in hemolytic disease of the newborn. Why I am saying, because after the newborn is born, there are a battery of tests that are done routinely to the newborn to check whether the newborn have any disease or not. So with these screening tests, we can determine that whether the newborn have hemolytic disease of the newborn or not, thalassemia, G6PD deficiency, pulmonary TB, iron deficiency anemia. All these things are detected by screening tests. So that fulfills the number one use, that is case detection. Number two use of screening is the disease control. So in disease control, what happens? It is the prospective screening again. We are doing it prospectively on individuals. Here the people are examined for others' benefit. Okay? We do it because we want that the other individuals who are surrounding the diseased people, they should not be affected by the case. So people here are examined for others' benefit. Mostly it is seen in the screening of immigrants for infectious diseases. Like, suppose you are going to an endemic country of yellow fever in Africa and all. So while returning to India, you will be screened for any symptoms of yellow fever, so that the population in India will not get affected from the yellow fever agent. Okay, so for others' benefit, the screening of the immigrants for any infectious diseases are done. The screening test will help to early detection of the cases. So early detection will lead to prompt and early treatment. This prompt and early treatment will lead to reduction of the spread of infectious diseases, and thus it will serve to decrease the mortality. Another example I may cite is that at the time of COVID-19 pandemic, our government of India used various tests of screening like the rapid antigen test, the RT-PCR, those coming from those who have the travel history from Wuhan in China or from other countries later on. They would be subjected to some screening tests, and so that the people in India will not get affected from COVID-19. So this use of screening test is the disease control. It definitely leads to early detection of the case, leading to the prompt treatment. This prompt treatment will help in reduction of the infectious disease to the community, and later on reduces the mortality. Next, coming to the screening uses again, the third is the research purpose. We do screening tests for research purposes also. It is to collect more information about the disease. To know the detailed natural history of a disease, we do the screening tests. Again, I want to cite the example of COVID-19 here. It was a very new virus, the new strain of Omicron and all. At the time, various agencies and government were trying to find the natural history of the disease. How virulent was it? So for research purposes also, we do the screening tests. We collect data, we analyze it, and then we come to a conclusion. But remember, when we are doing screening tests for research purposes, we have to inform to the participants that there will not be any follow-up. We have to take their proper consent that no follow-up therapy would be given after this. If they are willing, they can participate. And for the ethical standards, we must ensure that this particular information of not being follow-up must be given to the study participants before doing any research purposes on them. Next use of screening is for the educational opportunities. Here, when you are doing any screening tests in a population, then it has a role in creating public awareness about a certain disease. It helps us to educate the health professionals as well as the community about the particular disease etiology and its natural history. What is the natural history of the disease? How virulent the disease is? How much the population can be affected? Who are affected? When they are affected? What is the mode of transmission? How it can be prevented? All these information can be given to the community at a larger level by screening tests, as well as the health professionals get a hands-on experience of screening a large group of people from the community. Thus, it provides a learning platform for the health professionals to understand the disease etiology and the natural history of the disease. Now coming to the types of screening. Basically, there are three types. Number one is the mass screening, number two is the high risk or selective screening, and number three is multiphasic screening. This figure shows us all. See here, all the green color individuals, they are the mass. When you are subjecting a screening test for all the persons in the community, it is the mass screening. Suppose you already know these orange colors are those people who might have the disease of our concern, and you do the screening test among them only. This is high risk screening or selective screening. We are not subjecting all the people in the community to undergo the certain screening tests. We are only subjecting to those who might have the disease under study. With our prior knowledge, we do the screening test among them only, and if we do it, it is known as high risk screening. Next comes the multi-phase screening. Again, I want to cite the example of COVID-19 here. In the beginning, we were doing rapid antigen tests, that is one screening test. All this population are being subjected for rapid antigen test. That is the first phase. The persons who came out to be rapid antigen test positive, suppose these two, are again subjected to a second test. At the time of COVID, it is RT-PCR. So there were two tests done among the persons who have come out to be screen positive. So with these further tests, we will then advise to the concerned individual whether any action or support is needed or no action or support is needed. So since we did two screening tests, that is known as multiphasic screening. So this diagram covers it all. We would be discussing each type of screening in the next few slides. Coming to mass screening first. Mass screening, as I have already told, it is the screening of the whole population in the community. When you are screening the whole population at a larger level in the community to detect a certain disease, it is mass screening. It was previously given much support, but now it is under critical review. Why I am saying so? Because it has been said that if we do it mass screening indiscriminately, then we will not have any outcome as such, unless we have a useful preventive measure backed by suitable treatment. Why I am saying suitable treatment? Because if it is backed by the suitable treatment, it will help in the reduction of the duration of illness, or it may even alter the natural history of the disease. So unless we are doing these preventive measures or any treatment follow-up after mass screening, it is of no use. Thus, now it is of critical concern whether we are doing a preventive measure following mass screening or not. Thus, it is under scrutiny now. Okay. Next, let us come to high risk screening. So, what is high risk screening? High risk screening is the most productive screening if it is applied selectively. Why I am saying so? Because if we get to know a certain population is at higher risk of acquiring a disease, and if we do some screening tests on them, then we may find some people among them who turn out to be disease positive. So, high risk screening has a major role in case detection. If I have to cite an example for it, let me tell you, just like the female sex workers or the men having sex with men, due to their activity, they are at a higher risk of acquiring sexually transmitted diseases. So if we are screening them for any sexually transmitted diseases, we are having a higher chance of getting some persons who turn out to be positive. Similarly, the workers working in a certain factory, just like marble factory, marble industry, ceramic industry, they are having higher chance of getting pneumoconiosis. Those persons who by their occupation are drivers, long distance truck drivers and all, so they are having a higher chance of scrotal cancers and all. So if we know due to certain measures some people are at higher risk of acquiring a disease, if we do some screening tests among them, it is high risk screening. So preventive measures can be applied before the disease occurs, because screening tests we are doing it upon the apparently healthy individuals, and on the top of that we know that those individuals are at higher risk of acquiring the disease. So if we do some screening tests there, we are having a higher chance of detecting the disease early and thus give prompt treatment. This will also be helpful for the economical use of resources. Now, the effectiveness of intervention is also high since we are detecting the disease early. That was all about the high risk screening. Now coming to the multi-phase screening. Multi-phase screening, as I already mentioned in my previous slides, that in multi-phase screening we are doing a battery of tests. It can be 2 or more tests, and these 2 or more tests may be in a form of questionnaire, clinical examination, or a range of measurements like laboratory tests or radiological tests. So if we are combining 2 or more tests one after the other or in parallel, then it is known as multiphasic screening. But some of the randomized controlled trials that have taken place in the world, they have concluded that the multiphasic screening have no considerable benefit to the community. It only increases the cost of healthcare. Thus, we have to be sure that whether we require a multi-phase screening or not. Now, finally, let us discuss the criteria of screening tests. So when we are selecting a screening test, what are the factors that we have to look for and why it is important? Let us discuss it. Number 1, the acceptability. While deciding that this particular test is going to be a screening test, we have to ensure by pilot testing and some interviews that whether that test is acceptable to the community or not. Suppose uh, I will give you one example, like for cervical cancer screening. In the beginning, if you directly go for uh, colposcopy and all, so it is not much acceptable to the community. So the VIA test that is done for cervical cancer screening, it was seen that it is much more accepted than colposcopy and all. So we have to ensure that whether that screening test that we are going to do is acceptable to the community or not. If it is not acceptable, then it would be a failed procedure for us. So acceptability is very much important as a criteria for labeling a test to be a screening test. Number two, repeatability. Whether our screening tests can be repeated in different settings and whether this test will give the same result, it is important to us. If it cannot be repeated in different settings, then screening tests have no role. Thus, while selecting, we have to ensure that it is repeatable in nature. And not only repeatable, it should be accurate, and the results that is obtained from a screening test, it should be valid. If it is giving different results in different point of time, then the screening test is of no use. If it gives continuous results when we are repeating it, that means it is valid and it can be labeled as a screening test. So repeatability and validity both are important. Then comes the yield. Yield means, since we are doing the screening tests among the apparently healthy individuals, though those individuals will not know whether they are diseased or not. Our screening test will determine them whether they are diseased or not. So the screening tests, if this test is able to detect more number of true positive cases from the community of apparently healthy individuals, that is known as the yield of the tests. So if a screening test have a much higher yield, then we will say that our screening test is a success. So yield is also an important criteria of a screening test. Then comes the safety. We must also ensure that the screening test that we are performing on the apparently healthy individuals are safe. If it is not safe, and if it jeopardizes the life of a person, then we cannot treat the test as a screening test. As we are doing it among the larger population, the screening test must be safe. And how quickly the results are given by the screening test, it is also important. We cannot use a test that is acceptable, that is repeatable, that is valid and have a higher yield and is also safe, but if it gives the result after a very long time, then the screening test is of no use. The basic use of screening is to detect the case in its early stage. If it is not rapid, the results are getting delayed, then the basic function of a screening test is lost, and so the rapidity by which a screening test will give the result is important to us. Next comes the ease of administration. Ease of administration, because I have already discussed, the screening tests are not done by qualified healthcare workers. These are done by the field level or the mid-level workers who may or may not even know the technicalities of medical field. So for their ease of administration, the screening test must be simple. It can be done by any persons with some knowledge and training. Okay, it should not be complex. So it should be ease of use and ease to administer. Then only screening test will be a success. Otherwise, if it is a complex procedure, then and if it requires a medical personnel for it continuously, then the screening test will not be fruitful. It should always be easy to administer. Then only the screening test can be considered as a screening test. And lastly, the cost. The screening test, since it is done among the uh, large population, the cost should be minimum. If the cost is high, the screening test will not be acceptable. And if it is not acceptable to the community, then the basic function of screening test will be lost. If all the points are satisfied and the cost is high, we have to remove that tests for screening. We can keep it for diagnosing, but for screening test, the cost is a factor and the cost should be kept to a bare minimum. These are the criteria to choose a test for its screening. That was all for this session of screening of a disease. I hope you do get the concept of a screening test, the iceberg phenomenon of a disease, the screening types and what are its pros and cons, when to use it, and the criteria of screening as such, and what are the different criteria on which a screening test depends upon. So these are all viva questions, as well as it also comes as a short note in your exam. I hope I could justify the topic before you all. Thank you for listening to me. That was all from my side. If you have any questions or doubt, please feel free to put it in the comment box. I would be happy to answer them. Thank you so much.